Hey guys, welcome to this week's case. Now, what do you think about when you see an elderly patient recovering from COVID-19 pneumonia who presents not with chest pain, but shortness of breath and dizziness with exertion in the setting of the ECG that I'm going to show you in a second? Take a look at it and see what you think. Okay, so here's the case. This was a 78-year-old female recovering from COVID-19 pneumonia with 2 weeks of progressively worsening fatigue, but improving with her respiratory symptoms. Now, she also complained of mild shortness of breath, lightheadedness while walking, and denied having any chest pain, fevers, coughs, or things like that. Now, she was ill appearing, slightly hypotensive, but the rest of her vital signs were okay. Now, here's her 12-lead ECG in the ED. Take a look at it and go ahead and pause the video now and see if you can put the interpretation together. Now, let's just highlight the really abnormal things. The rate was 72 was good, but the rhythm was quite irregular. There was a leftward axis. The intervals were abnormal because there's no PR to be seen. The QRS was wide, and the QT seemed to be prolonged also. There were no STT wave deviations except for just benign, non-specific things, but there were Q waves, especially Q waves in the anterior precordial leads. So given these findings, she was kept in the ED, monitored, and suddenly she became, she experienced more palpitations now, and she had this ECG. And looking at this, well, there's some PVCs here, and more pronounced again here. And several minutes later, it was discovered that she was actually on citalopram for depression and was started on Levaquin, presumably for a pneumonia that was developing. And this is the ECG that occurred a few minutes later, 5 minutes later. This was, in fact, torsades that was picked up quite by chance because she was being monitored so closely. And if you look closely, you can actually see QT prolongation. I hope you see it there. Let's go ahead and blow this up a little bit and if you look at the RR interval here, there's the QRS, and really the T wave should be done before the halfway point of the RR interval. And here you can see quite clearly that it actually goes way beyond the halfway point. So this was in fact a prolonged QTC of about 570 milliseconds, quite abnormal. Okay, so this is what the rhythm looked like in magnification. You can actually see that you actually literally have twisting of the points here. That's where it gets its name, right? She was actually asymptomatic throughout the entire episode, did not lose consciousness, but felt somewhat lightheaded and had palpitations. She was treated with magnesium, and the torsades resolved completely. Now, the patient was admitted to a monitored setting, had no recurrence, and she was discharged in really good condition. Now, just to quickly review torsades, there's a range, the range of normal with males and females, with the upper end of it being about 460. And we really get concerned when the QTC hits the 500 millisecond mark, in this case, she actually did. There are a bunch of things that can cause it. Besides the congenital long QT syndrome, there are other things like drugs, drug combinations, electrolytes, and other physiological conditions like subarachnoid hemorrhage can also cause this. So keep that in mind also. Remember that medications are a vital thing to get a history on, right? So there are about 135 known medications that can actually cause QT prolongation. So getting a medication history is of paramount importance in someone like this. Electrolytes, well, hypomagnesemia, hypokalemia, and hypocalcemia can all, result in QTC prolongation. So, keep that in mind. Now, the take-home points in this case, well, never let a benign sounding story in patients who are at risk dissuade you from getting a complete workup done, and always get a complete history, including a medication history that is sometimes quite difficult, but absolutely important to do so. And treatment with torsades, well, it's magnesium if they're mentating okay, but if they don't mentate, if they aren't mentating or they lose their airway, you have to think about cardioversion for sure. And remember, elderly patients, and especially women with atypical symptoms, you've got to think about this being something more than just something benign, and always have a low threshold to get a 12-lead ECG. Well, that's all for this week, folks. I hope you enjoyed this case. Until next week, this is Sush. So long.